Hi, and welcome to the Focus on Eye Health Expert Series. I'm Jeff Todd, CEO at Prevent Blindness. And joining us today to talk about diabetes-related eye disease is Professor Neil Bressler of Johns Hopkins University and the Wilmer Eye Institute. Thanks for joining us, Neil.
Jeff, thank you for letting me participate in this.
Sure thing. Dr. Bressler, could you please tell us a little bit about yourself and your area of expertise?
Sure. I'm a professor of ophthalmology at the Johns Hopkins University School of Medicine, where I was chief of the retina division for 13 years. My practice there includes retina patients. Many of them have diabetes. In addition, I have pursued in research, clinical research, especially designing and overseeing clinical trials. For example, the NIH-sponsored Diabetic Retinopathy Clinical Research Network.
And what led you into the field of ophthalmology?
When I was in medical school, ophthalmology at Johns Hopkins had some wonderful mentors, and they introduced us to the field to show us really how broad you could be in ophthalmology. That is, you dealt with children, you dealt with adults, you dealt with emergencies, you dealt with chronic disease. Sometimes they were diseases just involving the eye. Other times they were connected to the whole body, the whole system. And so that was very appealing. Also, you could treat things medically, you could treat things surgically. And finally, it was my impression that there wasn't a lot of clinical research going on in the field at the time. And so this was an area that you could go into and begin to study some of the most common diseases that were affecting the eye, because there was plenty of room to do research in that area.
Got it. Very interesting. I understand, in addition to all of your work at Johns Hopkins and Wilmer, you're also the editor-in-chief of JAMA Ophthalmology. What role do journals such as this play in advancing clinical care and clinical practice around eye health?
That job has been such a delight, and that's because it's the type of job that touches everyone in your field. I mean, it touches all the ophthalmologists around the world. It touches vision scientists dealing with ophthalmology. It touches any healthcare provider who's helping people, and many patients read about it as well. So when I was given the opportunity to do that job, I was ready to take it right away. What an editor does is, first of all, work with authors around the world so they have a chance to present their most recent clinical research that either provides hypotheses that might change how we practice, and those are subsequently tested in clinical trials, or to actually publish those clinical trials that often change how we practice for the better. And so this was an opportunity to be a part of that. And then to work with people that you bring on the board who can assist you as either reviewers or editorial board members to not only review the science that's being presented, but then reach out to people to provide expert opinion on what's being presented. And all of this is designed to get out to the world how to take care of people with ophthalmology diseases. And that was just a great job to have the opportunity to do.
I bet. Well, so today we're here to talk a bit about diabetes-related eye disease. Prevent Blindness is acknowledging November as Diabetes Eye Disease Awareness Month. I know this is a specialty of yours. What drew you into this area of specialty at Hopkins or in your practice?
Well, I mean, ophthalmology and just vision diseases mean so much to people. We even participated in a study that was published a few years ago looking at how important vision is to people. I mean, this is a well-characterized survey that asked, what's the worst thing that could happen to you? Is it losing your vision? Is it having AIDS? Is it having a stroke? Is it having a heart attack? Is it having cancer? All of those are devastating. But the study showed that one of the worst things that could happen to someone is going blind. And what was especially poignant about that research is it was true across all races and ethnicities in this well-characterized sample of people from the United States. So it's obvious that when you work in this field, you begin to recognize what was shown by that paper scientifically, that vision and avoiding blindness, or trying to get someone from losing vision to getting their vision back, is so important. And so that just attracted me to ophthalmology and attracted me to retina, because two of the most common causes of vision loss that can lead to blindness in the United States and many parts of the world are an aging problem of the retina, termed macular degeneration. And another very common problem is that diabetes, one of the main problems it can do, and it can do many problems to the body, but one of the main problems it can do is affect the retina, which can, if left untreated, so often go on to blindness.
I remember that study. That was such a powerful piece that we still use today to emphasize the importance of addressing vision as a public health concern. So what are some of the symptoms of diabetes-related eye disease or retinopathy?
Well, probably one of the most important symptoms of diabetes is that as it begins to damage the eye, there are no symptoms. And this is so critical because there are so many people that have diabetes. And even if only 5 or 10% of them at some point in time may have some damage to their retina, many of them won't know it. And so the most important symptom is that there's no symptoms at all. But as the damage worsens, a person might begin to notice some blurriness to one or both eyes. They may first think, maybe my glasses prescription isn't correct, or maybe I need better magnification for reading, which of course it might be what is going on, or it could be a number of other things as well. But it also can be a sign of the problems that can happen from diabetes. But it typically is not recognized at first. At first, there are no symptoms, and only when it becomes much more advanced might a person notice that there's vision loss. So we don't want people with diabetes to wait to get their eyes examined when they have blurry vision. We actually, as I'll speak with you, want people, no matter who they are with diabetes, to begin to get their eyes examined right away, because the earliest problems have no symptoms.
Yeah, exactly. Those of us working in public health and vision have been hearing a little more lately about macular edema, I think largely because there are more treatments coming out for it, luckily. Could you explain a little bit about what macular edema is and how it relates to retinopathy?
Yeah, sure. So the macula is sort of a geographic location. Like you might say, Nebraska is in the middle of the United States. The macula is in the middle of the retina. Now, the retina is the light-sensitive tissue that lines the back inside wall of the eye. And the way we see as light passes through our pupil, everything is transparent in the eye until that light gets to the back inside wall of the eye, which is the retina. The retina then makes a picture of what we see, but the macula in the center of the retina is very specifically designed to do very fine vision. It's designed, and it's the only part of the retina that could, for example, see small letters when we're trying to read or look at our phone. It's designed so that's the part of the retina that we need to recognize somebody's face or to be able to drive to see at far distance. So macular edema affects the macula. And what that is that in diabetes, some people, because of the elevated blood sugar levels, can damage the very small capillaries to the center part of the retina, to the macula. And those capillaries then no longer have good blood flow to the center of the retina. And that poor blood flow makes the retina put out factors which can cause leakage of the capillaries. So just to review that process again, the high blood sugar leads to poor circulation because the small blood vessels no longer can provide good nourishment to the retina. The retina, in response, puts out these factors that can make the capillaries leaky. As they begin to leak some fluid, the retina sort of swells like a dry sponge swelling with water. And that swelling is termed edema. And that's what we mean by macular edema, which could be from many causes, but the most common cause is diabetes damaging the small blood vessels, causing this swelling in the center of the retina, this diabetic macular edema.
Great, thank you for that explanation. So what treatment options are available for diabetes-related eye disease?
Well, we have a few treatments, and they basically are injections into the eye of medications that I'll explain, or applying laser through the eye onto the retina. So let's talk about the injections first. The injections are the most common way that we treat diabetic macular edema now. And basically, it is injecting into the eye factors that can oppose the very factors that were causing leakage. So if you have these leaking factors, you can inject this anti-leaking factor. The factors that cause this leakage are called vascular endothelial growth factors, or VEGF, and you can inject into the eye anti-VEGF. Now, when we first tell patients perhaps that they have diabetic macular edema and we want to inject an anti-VEGF into their eye, they might want to run out of the room. But in fact, we tell them this is not very painful or very uncomfortable for the eye, because we use a needle that's about the size of a hair. It's very tiny. And just by putting numbing drops on the eye, you often can just press lightly with this tiny needle, like pressing a hair against the white part of the eye to get the medication in. Now, it's not a one and done medication. Typically, that medication is metabolized inside of the eye. It might only last a month. And you might need to give this medication 5 or 6 times in the first 6 months. So each month, maybe 5 or 6 times, to begin to get this edema under control. You may need to monitor this person monthly thereafter until 1 or 2 years to determine when do they need additional treatment, not necessarily monthly, but perhaps 3 or 4 times over the next year or so after that. So it requires a lot of intensive care, many visits, but indeed the benefits are that you almost never lose additional vision then if you are able to get that treatment in. And if there's some vision loss, many times you can get much of that vision back. So a very intensive monitoring and visit for the patient, but a medication that very often can get rid of the diabetic macular edema. That's the injection or the anti-VEGF treatment. Now, the laser is another way that you can treat this. In fact, laser was the first way that diabetic macular edema was treated. Back around the mid-1980s, the National Eye Institute reported that you could use laser and reduce the chance of this edema causing worse vision. About 40% of the people left untreated lost a lot of vision over 3 to 4 years. And if you applied laser, it was only 15 or 20%. So that was a step in the right direction. However, there was no other treatment from the mid-1980s until 2010. And around the year 2000, as it was recognized that the proportion of people developing diabetes was increasing tremendously, in part because the number of people developing obesity was increasing tremendously, many people went to Congress and said, we need more funding to help find new treatments. We haven't had anything else for this diabetic macular edema since the mid-1980s. Fortunately, Congress agreed to increase funding for all sorts of complications from diabetes, including those in the eye. And this led to the establishment of the DRCR Retina Network, which was instrumental, along with other companies that developed these anti-VEGF agents, in finding ways to treat macular edema, not with laser, but to use this anti-VEGF, which was then found to be superior to laser, such that only 5% of the time was there any vision loss instead of 15 to 20% of the time. And most of the eyes could gain or get substantial vision improvement as long as you identified it early enough. And that's the key. You don't want to wait until the person's lost a lot of vision. If you can catch them early on, you can keep most people to excellent visual acuity.
The advancements over the last several years have really been tremendous. And I'd certainly be remiss if I didn't say that while we've appreciated the continued investment from Congress in eye care, there's still so much more that needs to be done. And anyone who's interested in being a part of advocating on behalf of vision and eye health at the federal level can certainly visit our website at preventblindness.org to do so. We often think about retinopathy when it relates to diabetes, but we also know that people with diabetes are at a higher risk for glaucoma and cataract. Why is that?
Well, I'll discuss that in a minute, but I want to point out diabetic macular edema is one of two problems that can happen from diabetes affecting the eye. So I just want to mention one other because it's very important. It may not be as common, but very important. I mentioned that the high blood sugar levels can lead to this poor circulation to the center, to the macula. But that poor circulation can happen also to the rest of the retina. And if it does, many parts of the retina might put out these growth factors that cause new blood vessels to grow on the surface of the retina and scar tissue to grow on the surface of the retina. And this can cause substantial bleeding in the middle cavity of the eye. And this can cause even scarring that detaches the retina off the back wall of the eye. We term this proliferative diabetic retinopathy. Fortunately, it can be treated with laser if caught early enough, or it was recently shown that alternatively, not better, not worse, but you could use these injections, as we described for macular edema, to treat proliferative diabetic retinopathy. And rarely we have to actually go in with surgery to remove the blood or remove the scar tissue that's detaching the retina off of the back wall of the eye. So it's important to recognize that this diabetes can cause two problems that fall within damage to the retina: diabetic macular edema and proliferative diabetic retinopathy. And fortunately, we have great treatments for this, but now getting the word out to work on that is going to be critical. Making it feasible for people to get that is going to be critical. And we really have a long way to go in terms of trying to monitor and catch these. Now, you brought up, what about these other problems that might be related to diabetes other than the retina? And it's true that having diabetes can also cause some damage to the lens in the middle cavity of the eye. And when that lens becomes more opaque, we call that a cataract. So having diabetes might increase your risk of developing a cataract, although just with age, we might develop a cataract as well. And having diabetes in its very severe form might cause growth of blood vessels and scar tissue towards the front of the eye, where fluid flows to normally provide nutrients to different parts of the front of our eye. That flow can be interrupted by scar tissue growth in the front of the eye, which can lead to a very devastating glaucoma. So diabetes can cause so many problems throughout the body that we must work on, but one of the most important to ourselves is the effect on the eye. And while we typically think of it affecting the retina, it can contribute to the development of cataract, and occasionally it can contribute to a very devastating glaucoma as well.
Are there certain populations that are at a higher risk for diabetes-related eye disease?
Well, because it's so critical to identify this at an early stage, and because it's so critical to monitor and pick up when it's first developing and then know how to treat that, people that do not have good access to healthcare are at the highest risk. So whether that is a young person or an old person, whether that is someone of African descent or of Asian descent, no matter who the person is, having inadequate access to healthcare is the greatest risk, because these people may fail to get an eye exam, they may fail to detect this earliest stage, they may not notice anything until suddenly both eyes have developed bleeding from the proliferative stage, or they walk into an emergency room for the first time. While we could have perhaps years before identified the earliest stages, treated that with these anti-VEGF injections or laser and prevented that. So the biggest risk is for people that do not have access to healthcare, no matter what the race, ethnicity, no matter what the age, no matter what the socioeconomic status.
That's such an important point. Even in this country, while we might have the treatment, that doesn't necessarily mean people are getting it. And access to care is the key driver here.
We need so much more work. Maybe in the future, we'll be able to monitor people at home or in some way through their phones. We need ways perhaps to bring the care to them. And I think these are some of the very important next steps, in addition to making these injections more feasible, where you might not have to do them monthly, or you might not have to monitor monthly as well.
Yeah, you alluded to this earlier, but I think one of the concerns that we have is that unfortunately, because of obesity and a number of other things, we're seeing people get diabetes at a much younger age, which means they're likely getting eye problems at a much younger age. So I'm sure you're seeing patients much younger than you did a decade or two ago.
Absolutely. And this just means it's a systemic problem where we have to have all people working in medicine work together, public health people, to work on all we can to try to recognize the obesity problem, try to reduce that to the greatest degree. And yet still, even in the absence of obesity, some people will develop diabetes. And so our work is not done, as you said.
That's right. So you mentioned earlier the importance of early detection. How often should someone with diabetes get a dilated eye exam?
Well, in any adult, let's start there. At the onset of a diagnosis of diabetes, they need an eye exam of their retina. Now, many people could provide this, and I think what the person with diabetes should say to their physician or their other healthcare provider, do I have any damage from diabetes in my retina? And either that person will say, I'm confident you don't, and that's fine. And you start there, and then you just follow each year to make sure, are you confident I have no problem from diabetes in my retina? Or the person should say, I don't know, I don't have the equipment, or I'm not confident to tell you, and get that person to someone who can look at their retina and say either, I'm confident you don't have a problem, I'll see you next year, or, there is a problem, here's how it might need to be managed. So it's just critical in any adult at the onset of diagnosing diabetes that they see someone who can tell them, and they should ask, do I have a problem with my retina? Are you confident it's okay? And if so, see you next year. Or do I have any changes? And that's how we start the monitoring. And as we see changes, then we might need to see them more frequently, maybe twice a year, maybe 3 times a year. And when we notice they need treatment, as I said, at the initial stages of that treatment for a year or 2, we might need to see them to treat it monthly. Now, if we take children who might be diagnosed with diabetes, then typically it's probably best as they reach adolescence to see someone for the first time to say, do I confidently have no problem in my retina? And if the doctor says, I'm not sure, get them to someone who can do that. And if they're sure that they don't, then maybe every 1 to 2 years until they get into adulthood, they should be seen. And that is the best way to probably monitor and pick up the earliest signs that need more close monitoring, or to catch when we need to begin treating them. All of that maximizes the chance of retaining their vision to drive, to read, to recognize who they're working with or who they're enjoying life with.
You speak to a really, I think, interesting dynamic that's so important for us to address, and it's that communication between the patient and the provider, whether that's the primary care doctor, the eye care doctor, or whatever. And certainly, I suspect there is work to be done on both sides. We need to educate providers about how best to talk to patients, but we need to inform patients on what they should be asking about, especially patients with diabetes. They should be asking their primary care doctor, and it sounds like the first one is, Do I have retinopathy? And any other advice you would give patients on talking to their primary care providers?
I think that's the best way. You don't want to make it too complicated to advocate. We know from some very good surveys of population samples in the United States that maybe 40–50% have never had an eye exam. And yet, when we take an image of the back of their eye, in some of them, we already see damage from diabetes. Or they may have been told they don't have damage, and we take a picture of the back of the eye and we see they have damage from diabetes. So I think perhaps the best way is for everyone who has a diagnosis of diabetes, let's say starting in adulthood, to go to their doctor and say and ask them, do I have damage in my retina? And are you confident that I don't? And that way they know that things are okay, or they know that they have to go see someone else who can tell them, I'm confident you don't have a problem, or if you do, we have to treat it.
In this COVID era, we're certainly experiencing a lot more virtual care through telemedicine. In fact, yesterday I visited with one of my providers just like this on Zoom. How can telemedicine be used to address diabetes-related eye disease?
Well, I think it can help, and it's not the answer to everything. So it can help by using that to remind the person, have you seen someone in the last year to make sure your retina does not have damage? Or if it has had damage, are you following up with them? So the telemedicine can be a way of ensuring they're being monitored or that they're taking that monitored visit. Telemedicine is not yet ready to look in the back of the retina to see if there's any damage there that would change how we monitor them, or if there's any damage that now needs to be treated. So the telemedicine, the yes part is use that to remind the person that they need that monitoring, that look at the back of their eye, but it can't do the back of the eye yet. They need to go in a safe way. And I think most physicians have learned how to do this safely. Most other healthcare providers have learned how to do this safely. So they shouldn't withhold that visit to look in the back of the eye because of the pandemic. They should just make sure they do it to preserve their vision in a safe way.
Well, I really appreciate you spending time with us today, Dr. Bressler. As we wrap up, is there any final message you'd like to share about diabetes-related eye disease or eye care in general?
I think, as you pointed out, it's something that we've come a long way, so we can really do a lot for that person. They have to be their advocate to get into the system, but we really have a long way to go. And so I'm just so appreciative from the bottom of my heart of all the work that you do to your organization to get out and, number one, educate people about what the problem is, and number two, help support the research that's so needed, because the way we're treating it now is not the way we were treating it 20 years ago, and we're helping so many more people, but we do have such a long way to go. So thank you so much, Jeff.
Well, thank you so much for being here. And I'd strongly encourage anyone who wants to learn more about diabetes-related eye disease or any other eye condition to visit our website at preventblindness.org or to follow us on any of our many social media channels. Thanks so much.